So I think that my understanding is that the aim of this focus group discussion will be around the translation of knowledge into practice. So as Tom said earlier on in his presentation, currently the evidence at this stage comes from publications related to interventions. These sometimes take the form of legislation, guidelines, NICE guidelines. There is a push towards clinical decision support systems, which have been used and they are using closer to practice. However, one of the problems which we have faced very often is this relation to implementation. In particular, although there is now quite a lot of evidence in relation to new interventions, they very often fail to become part of recognized practice. There are different ways and different kind of approaches that have been applied to identify reasons why, both from health psychology point of view and behavioral change kind of approaches and interventions, as well as from more kind of social sciences and sociological approaches, which are trying to understand what really normalizes behavior and what really makes change enacted in practice. What are the kind of things, factors that shape change. So I suppose what we would like to discuss today here, it is from your experience, your understandings. I mean, what are the main kind of barriers or facilitators that would enable and shape the enactment of learning health systems in practice? So what are these things which that will play an important role in actually in order for this system to have a real impact in shaping practice? And if so, what are the mechanisms to deliver this? So my role here is just to facilitate, provide some kind of ideas, and it's more about you guys to think issues in relation to the implementation, because I think it's about implementation, isn't it? And I think what somebody was saying earlier, that there are two kind of realms in a way. There is the technology and the social. So I think that's we all agree that learning health systems represent socio-technical systems. So there are social kind of arrangements and technological arrangements about how these different kind of realms become embedded to each other and shape practice. So there are structural kind of elements and things that happen in organizations, social users kind of stuff. So I would like to unpack your thoughts and kind of ideas in relation to implementation.
One of the things that I just respond to that. One of the things that struck me in the introduction that we've just listened to, which was obviously hot foot after a tour of a number of key sites in the States, is whether today we're going to sort of have a sort of a broad international kind of discussion, or whether we're going to sort of think UK NHS. And I think the answer to your question varies hugely in different domains of health services, and something which would be relevant experience and relevant conclusions in the context of those centres in the States wouldn't necessarily, although it would chime and it would ring bells, it wouldn't necessarily go to the heart of the matter in an NHS context. So I suppose that's just a response to sort of know, are we thinking NHS here? Because there's a huge amount in the domain just in that context, and to what extent do we want to think more widely than that?
There's another kind of way of cutting that cake, which is different areas of healthcare. I refereed a paper way off my competence about innovation in surgery, and it obeys a set of rules which are rather different from a set of rules which innovation in mainstream sort of physician practice obeys, and it's probably not evidence in publications. It's probably a much more social practice. Yes. Was what I took away from that particular assignment, which, as I say, isn't my speciality at all. So I think we've got to be careful about it. It all starts with evidence in publications and guidelines. I think that's one place to dive in, but it's not the only place to dive in.
Yeah. Before we proceed, I forgot to mention that are you happy, some of you, to feedback later on to the groups because this is the aim, so we're going to have, you know, this workshop and then, you know, one at the end of the day, and then who is happy to just present all kind of ideas.
So you're not the rapporteur?
Well, I'm just, you know, to facilitate the discussion, but, you know, if you're happy, one of you just, you know, to bullet point some of the points and, you know, just 5 minutes to give back to the when we get back later today.
You're looking at me very hard, I have to say.
No,
I'm very
because your expertise, that's why.
No, I'm very opinionated, and I think I might not do justice to a balance.
Tony, are you happy to do so?
No, I'm more opinionated.
Anybody not opinionated?
Anybody is happy to do so? Are you happy?
Yeah, I mean, I can have a go.
Wonderful.
So,
Yeah, and we're going to have, you know,
You're allowed to be opinionated.
Thank you.
I mean, are we talking about, so where they talked in the other room about interoperability, which I didn't actually know about, are we talking about that level of challenge in terms of so organisations not working properly together in order to progress this, or are we talking on a more practical level?
I'd like to respond, because partly to respond to the earlier remarks, because the two things that came to mind, which I think will address that question, for me, which might be idiosyncratic, but I hope not. But I don't feel they are either national or international, biased in any particular way, or even specific to any particular medical specialty. You know, so I think the kind of two things that popped into my head, I think for obvious reasons, were one was loosely called socio-technical, though as a psychologist, cognitive scientist, it's more at the kind of individual human level than the organisational level, and the other is technical. And that's where the interoperability will pop in. So at the human level, it seems to me that one of the major obstacles to everything I've been trying to do for almost a career now is that what we as scientists, technologists, engineers, whatever we may be, are trying to offer to improve quality, safety, improving practice, is pushing into a world in which there are huge numbers of people who are extremely skilled already. I mean, there may be room for improvement, and we know there is, but they're very skilled. They have very strong cultural traditions about what the nature of their work is, what their responsibilities are, what machines could possibly do. And of course, a lot of that is supported by we as patients who expect certain things from the role of the medical professional. And learning how to overcome the obstacles that our technologies simply don't fit with those human ways of thinking and those maybe organisations and institutions is for me, you know, that's a kind of a lifetime's kind of riddle that we're still trying to kind of hammer away at. The technical side, which I think David and I will kind of meet absolutely in the middle on this and speaks to interoperability as well, is that everything I do in trying to improve knowledge into practice and to help to improve quality of care is completely dependent on having easy access to data, to clinical data, and in a standardised and open formats and so on. So if we can't link up the clever techniques that we've got to the electronic medical records and do that easily, whether it's a hospital with Cerner or Epic or all the different providers, the vendors of EMR systems, then it's very hard to get any lift at all. And this, of course, is directly related to interoperability because all these systems have got to talk to each other as well as talk to us as the providers of point-of-care services. They've got to talk to machines, they've got to talk to databases, they've got to talk to communication systems and so on. So standardising medical terminology and standardising, which is, you know, David knows vastly more about than I do, and standardising the meaning of clinical terms is a huge technical problem.
And getting the practices lined up with that kind of data. I have a student at the moment working as a master's student writing an essay, but about proteomics, the challenge of proteomics data versus the ease of genomic data. Genomic data, sort of one person, one genome. Proteomics data, one person, God knows how much proteomics, because you don't really know where to go looking for it, and it's, you know, so I think these things scale. We start with the electronic patient record, that's tough, perhaps, you know, pragmatically it's tough, but there are bigger challenges on the horizon of what's the practice in a hospital or clinical setting to put proteomics into the mix. We can do it in a research project, but what it means in 20 years' time when the standard district general hospital is, you know, running on proteomic, if it is, eventually. You know, so these problems get more and more difficult, and they have to be translated into new work practices even before you really get the data. Before you can feed it back, you've got to put some work practices in there too.
Yeah, I think I'm maybe repeating your 2 points. I think, which so when we're thinking about modelling systems, healthcare is very complex, and everything is connected to everything else essentially. Or lots of variables are connected, and change in one part of the system causes change in another. And so when in the introductory session we were talking about revolutionary change, it's hard to see an entry point without having an effect or an unintended consequence in another part of the system, and particularly along with the social technical constraints. And so that's, yeah, the resistance to change within these types of complex social and technical systems, when you've got lots of existing actors who have varying levels of power. There's, yeah, it's hard to contextualise that revolutionary change with how the system has and will work.
And revolutions usually don't change everything. They usually reinforce long-term trends. You know, revolutions don't take you off your path, they get you back on your path. And that's the social science historian.
David, you come very much through open air and thinking about it in terms of we've had similar experiences in trying to introduce a technology, in your case in terms of clinical data modelling, in my case kind of service modelling. Is that distinction that I made between
I think it's
the technical and social technical, is that a reasonable starting point?
Yeah, I mean, I suppose you know, come back to your question about what are the barriers that we're facing, which I was thinking when we were listening to the introductory presentation that the first time I suppose I heard the term learning organisation must have been in an NHS strategy document. And I hesitate to put years on these things nowadays because of my memory, you know, my memory kaleidoscopes, but probably about 30 years ago, the NHS was parading itself as a learning organisation. And yet in this field we're talking about today, of all, and these issues have been on the top of the agenda for at least that sort of time in the context of the NHS. So how come the NHS has forgotten so much of what's gone on in the last 30 years if it's a learning organisation? And I think it probably comes into Tony's domain here. I think it's very easy to paint these sort of vanilla kind of strategies in and around, you know, putting words around the problems, and you know, they do get more complex in the way that Tony's been describing there. Well, I think there's something missing in the middle of that lot about behaviours in the context of seeing yourself as a learner. Part of the problem in this kind of area is that we're dealing with complex issues that are not really owned anywhere. At least they're owned in multiple different places, all credibly. There aren't right and wrong answers often. You need to experiment, you need to work out in the context of real life what's working, what's not working. So you need to be building a body of knowledge about the kind of process that we're involved in here. And so you can't say, this is the problem, this is the way we're going to tackle it, here's the solution, etc. It's much more evolutionary than that. And at the same time, it's all highly political. And one of the key barriers, I think, which I would put on, I once heard a head of R&D of a major pharmaceutical company talking to the Royal Society saying that you could capture the problems of the pharmaceutical industry in 3 timescales. One was the one that's already been quoted, 17 years from the lab discovery to the textbook. The second one was that politics comes and goes in about 5 years. And the third one was the stock market kicks you out within months. And I think we are confounded in this arena here with this kind of problem of an extremely intractable problem where there's a huge amount of learning required, using that word, and yet we're not really configured to learn.
We're slightly over-endowed with experts occasionally. I think of the national programme in exactly those terms. As a learning exercise, it would be a great success.
No, not. Because it's all been for all the lessons.
No, I'm not sure. You don't want to learn.
I've seen 4 national programmes.
Right. But that's what national programmes are like. They aren't, you know, something that you can either tick the box or damn it to hell. You've got to sift through the ashes and find the bits
But
that
nobody
you...
does. The ashes get lost.
I think some of the ashes don't altogether get lost. And we're drifting off our topic
anyway.
here. I mean, a favourite topic of provoking people by saying I think national programmes are a success. I'll tell you one very
There are
brief...
elements of, I'm not saying that.
Brief anecdote, when I did my PhD, we studied computerization in DHSS, Social Security. And we studied a project that failed, and the senior civil servant at the very end, when we interviewed for the last time, said it failed. He said, failed? What are you talking about failed? We got to deal with the unions, everybody had an eye test, we changed the furniture, we got air conditioning in the offices, they were rewired, we got new lighting, we got chairs, we got carpets, we got rid of a lot of ballpoint pens, we got computers on the desk. Oh, the application. That'll work next time. And it's always stuck me, that he's playing a long game. And the long game, I think, you know, is the way to approach these things is the long game, not the project with a, you know, end date evaluated a year after. Play the long game. Anyway, we're drifting.
We're people who play a long game.
I mean, we're all kind of in the long game, but in practice, I mean, you actually said something earlier, I thought, which I wanted to pick up on, which is to do with research into practice, and the research is typically a short game, it's 3, 4, 5 years. You know, particularly for people like me and David, you know, you do something which may be valuable, but by the end of that round of funding, there's no way of translating that into practice. You're moving on, trying to fight for the next grant. I'm not sure I know what the solution is, but at least within academic research and technical research, you know, there is the long game. It's very hard to play a long game. But I was pick up a point about the politics, which is why I'm sorry, I didn't get any from NICE. I didn't get your first name.
Nina.
Nina. Sorry, Nina.
That's good.
Because I'd like to sort of throw something in the air which may or may not be accurate. But there was a paper in General Royal Society of Medicine by Chi and Leng on the NICE guidelines programme, essentially kind of reviewing it and say the enormous resource, you know, it's the largest effort in the world to create clinical guidelines that capture best practice and that will guide the NHS in delivering high quality care, and saying, I mean, I liked the paper because it said we need things like decision support systems, but the it was essentially about the issues of implementation and talking a bit about the barriers. These paper documents or electronic documents of guidance, care pathways, quality standards, all these sort of very valuable stuff, very authoritative stuff that is produced. But everybody sort of knows it doesn't create change or achieve the kind of change in NHS that were its purpose. And I, with a number of hats on, have had conversations with NICE and said, well, look, you know, we can help to provide the technology that will take the content into a form that's machine usable, that can help, you know, kind of manage and actually deliver the guidance to clinicians at the point of care. And lots of interest, lots of discussion, but somehow no action. And I don't know whether that is a kind of generic issue to do with political inertia, or that there are too many voices all saying we've got the answer, and I'm just one of many, or whether there's something very more specific, and that is that politics with a big P, that NICE is in such a politically vulnerable and exposed position that it's tough enough, you know, to kind of keep the public with you in terms of the general policy. But then trying to say, oh, we're going to take our guidance, put it into computers that tell doctors what to do. That it's such a kind of terrifying scenario that actually it's not that there's unwilling, it's just there's no political route to achieve it. Is there any truth in that?
So I think the different levers. So I think slowly, as a kind of Borg ship, we're trying to suck in the levers. So, for example, British National Formulary now lives under NICE, and that through that we've developed an app which was pretty revolutionary for NICE. And that sort of information is in your GP computer. So when they're writing in what they want to prescribe, it does fling up contraindications and that sort of stuff. So there's a little bit. We have now a whole function at NICE. It's called. We've got a whole technological function at NICE, which is all about how we translate what we've got, our guidance, into usable stuff outside. We've moved our guidance and we have a new way of displaying that through a pathway system. So you don't go to the individual pieces of guidance, you go to whatever the disease area you're interested in, and it maps everything we've done in that area. So in some areas it's really well populated, in others it's well populated. So it will take you through all the surgical guidance we've produced, the technology appraisals on drugs, any medical devices, the clinical guidelines where they exist, any public health overlaps. So that can't all go on one page because it can be too massive. And then and then we've done stuff like how we translate that to get onto tablets because and smartphones, because that's what people are walking around with. They're not walking around with PCs. So there's bits and pieces happening and there's developments, but as always, it's probably not at the pace or getting to the end point quickly enough. But there is transformation and it is happening. Another one of our big problems is audience, and NICE has a very, very wide and varied audience, and trying to pitch everything we're doing for the different audiences and how to present it in different ways for the different audiences that are interested. Because some of our stuff you kind of have to do and there's legal requirements around it. Some of it is goes down to best practice and some of it's for information. So you know, and how to couch all of those different levels of information.
So I hear you saying that my conjecture that there's a political obstacle with the BP to delivering guidance to doctors, telling them what to do, is not actually an issue. It's just that everything takes a long time.
Yeah, and the mechanics, you know, not every doctor has a bit of kit that you could deliver something electronically yet. That's or if it is, it's, you know, I've got a Windows phone. I can't get all the apps my husband's got on his iPhone. He plays much better games than I do. But you know, what system are hospitals or doctors going to go with? Are we going to use private, our own kit? And then how do you make sure you've got the apps for all the different platforms? So I think that's one of the barriers, personally. I don't think there's a political barrier to it.
When it comes to decision support as a way of translation into practice, I had a conversation recently with a senior pharmacist who's managed implementations of prescribing and so on, who was saying, well, we've got to give up on the pop-up decision support, which we spent 10 years focusing on, and we've got to put it in differently. We've got to give the end-of-week prescribing report, or we've got to give the bonus point Marks and Spencer voucher decision support. You know, we've got to think this thing through, because while we pop things up on the screen, people will click them through. And that's all the evidence says. They reach 80–90% of click-through. You know, and it's part of the solution from this to a very clinically focused person is, let's just sit back and rethink how we deliver it in a way that actually there isn't going to be pushback from the start, or just blanking the whole thing and just getting through. I thought it was an interesting observation, and it was her observation that for 10 years we've sort of had this holy grail that things will pop up and tell you things. And now we finally woken up to the fact people hate things that pop up and tell us things. Yeah, they want to hear things, but they don't want them popping up in their damn screen in the middle of typing.
It's funny, isn't it? At a certain time, they probably did think that they wanted it
They
to
did,
pop up.
perhaps they did, yes, perhaps they did. But once they got, you can imagine a GP could have, you know, with a slightly complicated older patient, could have 7 bits of software on their system, each one of which is popping up at them. Have you done smoking cessation? Do you know about this contraindication? You know, when was the last time they had an angiogram? You know, and the GP is just like, enough! There's no more space on my screen for pop-ups. So it's an interesting conversation, I think, about rethinking not about the power of decision support, which I think we all believe in, but about the subtleties of how you deliver it.
And this is in relation, I suppose, with the disruptive nature of you know, of this sort of innovations, especially technological innovations. So, you know, I suppose it is how do we actually minimize, you know, the level of disruption to their existing practices. Because, you know, the example you just provided, that of the GPs having all these different systems, I mean, you know, that takes time. It is, you know, it becomes a bar on its own right. In terms of engagement and...
I'm not sure that you can, as a policy, seek to minimise disruption
no,
in that kind of way.
Yeah.
Minimise disruption is probably not disruptive.
Yeah.
I think what Francis said actually was, in the moment of prescribing, we're talking hospital doctors actually, in the moment of prescribing in you know, tertiary level referral centre, that person's thinking. They're not thinking, they're thinking about their prescribing decision, and that's why they get furious about the pop-ups, and it's the flow of their activity that you mustn't dislodge. At that point, you've got to let them think the way they think, and that's how they'll make the right decision. And I mean, obviously, there are crude decision support systems that just annoy the hell out of all of us, and we switch them off, don't we?
So how much does like human factors training and that kind of thing come into this in terms of getting through some of these barriers, if a lot of it's around the way we think and fit with technologies and the way they work?
Who do you think is being trained? When you say human factors training?
I mean,
Everyone?
Like, so in terms of thinking around the way we design systems?
Yeah.
I mean the providers are being trained in human factors.
Providers
Or
and the
users.
people developing?
Oh yeah, okay.
And the users. And the users.
Who is the user?
Yeah.
What's the question?
Each
Who is
one.
the user of this?
Well, the example I was thinking of, a very good example is the work Matthew Jones did at Cambridge on intensive care units. In comes the computer screens and the intensive care round that had 15 people, eye-to-eye contact going through the big chart on the table, became 2 people looking at the screen, a consultant and his senior sidekick, and everybody else twiddling their thumbs, no eye contact, no team effort in the thing. But the interesting thing about that piece of work was, it was the consultant intensivist who commissioned the work. He said, I've got this computer, I get all this data, but I've lost the team. You know, I need to know why the team isn't engaged anymore. Even the most lowly bay nurse in intensive care, you know, they say nothing until they feel they have to, at which point they say something. And you know, I wasn't getting those, they're cut out. And it was, I think it's just interesting that in that case, the user commissioned the research to find out why it wasn't working. You know, obviously, a consultant
the human factors side of things, one of the people I worked with in Leeds for some years was running the IT intensive care. And from ambulance to discharge from the ICU, patient data was going through 30 different systems.
Wow. Yeah.
Still.
See, I sort of understand what Tony says about the long game, but where I'm sort of focused here is that the market, going international here, the marketplace for all this kind of IT in the delivery of healthcare is, I mean, various quotes, you know, certainly in excess of $50 billion a year. Okay.
Worldwide?
Worldwide, yeah. Not in the UK. Well, it's certainly in excess of, I don't, you know, because people put numbers, but you're probably right. Now, I was thinking of, as we were listening at the outset, the framing of the issue for this afternoon, I was thinking of 2 publications, one from the American Office of Technology Assessment, a very, very good organisation that doesn't exist anymore in Washington. But in the 70s published some extremely good technology foresight kinds of documents, and they did one on healthcare and IT in about 1977, which is my primary sources on my bookshelf. I throw loads of things off my bookshelf these days, but that one's still there. And there's another one close to it by the American Academy of Medicine, I think it's called, which was from a medical educational point of view, and both of them were seeking to frame, not a million miles away from the problem we're describing this afternoon. And they're very loosely written documents, very clearly presented, and they framed it every bit as well as it's been framed. Okay, in a different world, a different context, you know, long game, the world is different now, etc. You know, we're all different, etc. But nonetheless, the fundamentals of it haven't changed. That's 40 years ago. So my concern in the context of an industry which is that big, and where the problem was formulated in that way 40 years ago, and where we've been through 4 national programmes, is I don't think we've got enough insight on why we're not learning. And I suppose Tony's sort of saying, well, we can't expect to, because everything's changing, and sociologically it's all a different game.
Yeah,
but I think we're wasting a huge amount of money, and I think we could spend it better.
We aren't.
I'm not talking about the national programme.
Yeah, we're not targeting it. But I had another thought thinking about this. You know, organisational learning is the easy bit. Organisational forgetting is the difficult bit.
Yeah, you've got to forget things. Absolutely.
You've got to forget things, and you've got to forget some of the horrors of things as well. You know, and not just remember them only for the bad. It's like, you know, I'm coming back to the national programme of the last decade. You know, we've got to remember it for some of the things it did do, and forget some of the horrors, because otherwise the horrors will haunt us forever. You have to sort of clear your head a bit. But it's a tricky thing, and human beings kind of do it if they're. Well, here we are with psychiatrists, they can tell us how they do it. How they balance their ability to remember and recall, but not be overwhelmed by, you know, the memories of their past, to sort of get up each morning and start again. I think we have to find some. No, my metaphor is sort of falling apart a little bit, but I think in some ways we have to. We do have to learn to live in this cluttered, messy world. The world will always be cluttered and messy, and human organisations will always be suboptimal, and they will always exhibit Machiavellian tendencies or like a kind of.
So are you saying there isn't a problem in need of solution?
There isn't a problem in need of a solution. No,
I'm trying to sort of.
I suppose that's the nature of.
We tack on against the tide, backwards and forwards.
Well, why don't we just let it happen then? Why do we need a national
strategy?
strategy?
We end up on a sandbank, so we have to keep pushing back.
No, I agree
with end of the great
Gatsby. You know, that's the kind of messy reality of practice, isn't it? And, you know, when we're talking about change, we're talking about change, you know, it's very incremental in this kind of landscapes. I mean, you know, things take time, and, you know, to normalise new behaviours takes time. And you know, the world is very, very messy, and there is not the problem, the solution. There is no cause and effect. I mean, we're trying to understand the complexities, and you know, the different kind of components that make things, you know, to be implemented and to change something. And there is another thing about, I suppose, you know, we have to question about, you know, what constitutes change, and you know, what constitutes success and failure. So we say that, you know, this system represents a technical system, so we have to apply symmetry when we assess success and failure. However, I mean, you know, Tom was saying that, you know, from his discussions with people in the States, so that, you know, most of the problems, not the challenges, not the problems, they are social ones, they're not the technical ones. So it is something which Wittgenstein, I think, he said that the problem of technology is not a technological one, it's a social one. And I think that applies in terms of, you know, the actual investment of learning health systems. Challenges, they are really the ones that they are pragmatic, they are the practice.
We can't do this in 40 minutes.
No,
it's not.
Are we at time?
I think it's just 20 to 2. I don't know. What time is it now?
It's coming up for 2:30.
Right.
Yes. Can I just pick up that last point and say that we hear the word ecosystem all the time, which is a sort of a rather grand word for trying to find some sort of happy medium between the big centralised push and just letting everything rip. I mean, but I'm not actually quite sure what most people understand by the word. I mean, technology ecosystem.
Yeah.
You know. You know, to what extent things are being pushed up from the grassroots, the innovation is happening.
Or that you require,
as opposed to the big.
you require, it's an ecology, you've
Yeah.
got to have everything in some sort of a balance.
It's
And
very
the balance
fascinating.
will be one that, it won't be static, it will be one that flows. I mean, if you think of an ecologist's
But the
idea
principle,
of-
it's never clear to me whether the principle is that you're trying to create a mechanism by which you can manage the balance between the centralisation that sometimes you need and the democratisation that you need, or whether in a very market-oriented interpretation of it is you make sure that things only survive if they deserve to survive, which sometimes is a government perspective and sometimes is an industry perspective. But I just kind of wonder what. But it sounds like everybody hasn't actually heard the term technology ecosystem.
We hear it. One version is
What does
sort
it
of
mean?
the Apple ecosystem, where it genuinely is a technology ecosystem. We all know Apple products work together, but they're kind of designed not to work with.
Yeah.
Anything or, yeah.
It's not that's a monopoly. That's not an ecosystem.
Well, they would say it's an ecosystem because
about
at
survival
the
of
heart
fittest.
you've got Apple, and then you've got all those app developers, some of whom are quite, and all the people who sort of click themselves onto the Apple ecosystem, and the wearables business, if that's sort of looking at the future. Is the wearables business going to be owned by Apple, or is it going to be owned by somebody else, or shared?
So
with somebody
you've
else?
answered. That's one answer to my question, which is you actually do not mean by ecosystem what I mean by ecosystem. So
Well, that's
Apple
one.
is not an ecosystem, but most of the people I hear using this term, they really do mean something which is much more
Organic.
anarchic and organic.
Yeah,
It's
organic.
absolutely
Self-sustainable
competitive.
kind of, yeah.
The word I don't hear you being used in a kind of precise sense is the word platform.
Yeah, that's
Because
interesting.
talking about centralised and decentralised systems seems to me a rather old-fashioned sort of pyramidal kind of thinking. I think talking about services and platforms, somebody in the first prior meeting said it's I wrote it down. We're in the transfer from a product to a service of the market, and I think platforms and services, are a little bit more concrete than ecosystems, and a little bit more interesting explanatory power in our kind of.
I mean, it's a term that's being used a lot more now. Actually.
It is being
Which
used.
one?
Yeah, absolutely.
Yeah.
And
So somebody I think we both know quite well, Ewan Davis.
Yeah.
And he's very critical. He set up an organisation called Handy Health, which is to free up the process of creating and disseminating apps.
Yeah, Handy. They're based in
Handy.
office, I think.
And no, they're based in Leamington Spa, but
Some people, yes.
yeah.
They're all over.
But they've been they're all over. They're all over. Yeah. But sorry, I've lost my way. Yes, what he thinks he's trying to do is to create a platform
yeah.
which is completely open source, open access. Anybody can put their application and make it available. So it's a kind of level playing field. He has a nice, I don't try to repeat it, but has a nice kind of critique of different views of platforms and how the big companies like Apple or Microsoft or whoever want to own the platform. So that everybody, as Apple does, and he says this is just not the way it's going to go.
Interesting, in the kind of economic literature, there is the idea of the platform as minimal core. And there's a theory of platforms, not the Apple theory particularly, but more the eBay theory, that eBay is a huge success because it does one thing, or a couple of things, well, and it doesn't try and take other than a very marginal bit of the deal.
Yeah, that's crucial in this.
Yeah. That it's the minimal core, and to be a platform you've got to say, I'm going to do this, I'm going to do it really well, my success is that everybody comes to me, but I don't want a slice of the value added. I want a very small slice, but own the minimal, as it were, slice of the value, because the value is going to be generated out on the periphery by the millions of people who trade.
Is that a model that OpenAI are?
OpenAI is at the heart of Handy. They're using content modeling based on OpenAI.
No. My question was:
sorry.
Is this the eBay model as
Yeah,
a business model?
Do a few things well is what I was hearing there.
Yeah, do a few things. Do a few things well, and be transactional. They talk about them as two-sided markets. A platform is a two-sided market. That's to say, you're facilitating some trade from here to there. Some patient data is being given to a pharma company. Some guideline is being traded to somebody who wants to build it into their planning or something like that. So it's this idea of a two-sided market or n-sided market. If you're an economist, it has to be n-sided market.